Upon Dr. Rahul. Rahul has finished his surgical retina fellowship from Shankar Nethralaya, Chennai, and is currently working as a senior retina consultant at Chaitanya, Cochin. He will talk to you on about electrophysiology simplified for a comprehensive ophthalmologist. Over to you.
At the onset, I would like to thank Dr. Sharath for this opportunity. So, as a VR surgeon, electrophysiology is something that we all kind of hate. The reason being, we don't. Most of this, the big institutes, they have this electrophysiology equipments, and we don't come across in a routine practice. So, I've been given the tough task of kind of simplifying it for a comprehensive ophthalmologist. I think it would have been apt if I had to simplify it for a retinal surgeon as well. So, ERG. So, ERG is an objective non-invasive measure of the electroretinal function. So, it's recorded on the cornea with electrodes. So, it gives you a diffuse, so it's basically a diffuse electrical response generated by the neural and non-neural cells within the entire retina on stimulation with light. So, it gives us a mass electrical activity from the retina. Now, when we look at an ERG, you have an A wave over here, which is a negative wave which originates from the photoreceptors. Then you have the B wave over here, which is a positive wave which arises from the bipolar and Mueller cells, that is from the inner retina. And then you have the oscillatory potentials over here. So these are small, wavelets along the on the ascending limb of this B wave. So these are called as oscillatory potentials, and they arise from the amacrine cells. And then you have the C wave, which is again a positive wave, which comes little later after the B wave, which arises from the RP. Now, when we look at the waves, we are also looking at the quality of the wave. So we are supposed to look at the amplitude, the implicit time, the latency, and also, so what happens is basically the amplitude is from the baseline to the peak of the wave. That is the B wave amplitude. And then you have the A wave from the baseline to the edge of the trough. You have the A amplitude, and that's how you get about the quality of the wave. So an important point is the B is to A ratio. So the B wave is from the inner retina and the A wave is from the outer retina, right, from the photoreceptor. So you give it a good information about the health status of the inner retina and the outer retina from this ratio. So small amplitude indicates reduced functioning of the cells, and when there's a delay in the time of onset to peak, which this indicates that the cells are sick or dysfunctional. Now, this is a normal ERG that we see. So we have something called a scotopic response, which is examined in done in a dark adapted state, and you have the photopic response. So simplified, scotopic response gives you an information of the rods, and the photopic responses give you the information about the cone system, right? So you have the single rod response, and you have the combined 30 Hz flicker, everything over here. So this is one thing that we should all know. This is the electronegative wave. So basically, when we look at the normal B wave, so we have the A wave first, and then we have a tall B wave usually. Now, in certain cases, you will see that after the A wave is normal, and the B wave is not that big. So that is the electronegative wave. But at the same time, if the A wave is also affected, that means that the rods are also affected. Okay, so this is a electronegative wave. So this is a normal this thing, ERG. You can see that everything others are normal, similar. But in this case, in X-linked retinoschisis, if you see the B wave over here, you can see that's very reduced in size. So these are the various conditions in which you get an electronegative wave. Now, this is an example of a retina RP, ERG of a RP. So most of the cases, just to simplify it, if you look at a normal ERG, you will see multiple troughs and peak amplitudes. This is what a typical ERG looks like. So you will have flat lines for both rods and cones, and the implicit sign will be delayed. So what is the significance of, is it just for the diagnosis of RP, the ERG? No, it also helps us in prognosis of disease, because what happens is many times when we in a familial screening, we pick up a case of early RP, they want to know whether they're going to lose the vision or whether the visual loss is still progressing. So with what happens is when you get a field test done or probably an OCT or whatever, you cannot comment about the progression. So this is the one place with ERG we can actually comment about, because if you see the amplitudes reducing, that indicates that the disease is still in a progressive stage. So this is a cone dystrophy. So if you look at the cone dystrophy, what happens is in the rod response. So cone dystrophy, the name itself is self-explanatory. The cones are more affected, the rods are little healthier. But still, if you see sometimes the A wave, the start of the A wave is delayed, and the B wave will be present, but it will be still little delayed in here. And the cone response is very extinguished. This is really near normal, and you can see that the photopic responses are affected. So this is a cone dystrophy. Now in inner retina, so especially CRAO, so we mostly rely on clinical examination or probably an OCT to get that thing, the diagnosis. But sometimes if you want to diagnose, you can also use an ERG, where what happens is it is one condition where you get unrecordable ERG, and most often in the initial stages the B wave is the first thing to get affected. Now, these are the conditions where you will find undetectable waveforms. So LCA, ophthalmic artery occlusion, gyrotrophy, the list goes on. Now, multifocal ERG. So it's a high resolution functional map of the retina, so of the central visual field. So you have in multifocal ERG, so this is what you get. You get a trace array and you get a 3D density plot. Now, most of us will just look at the 3D density plot and we'll say that this is the foveal peak, right? So if we say that the peak is kind of blunted, we'll say this is a kind of, some pathologies affecting the fovea. But you are actually supposed to look at this. This is the most important thing. So if you see at the waves over here, there are two negative waves and one positive wave. So you have the first negative wave, then you have one positive wave, and then one second negative wave. So that is called as the N1, P1, N2. So you're supposed to actually comment about on the basis of this trace array. So depending on, say, probably if an HCQ toxicity, I have a picture coming up. So in HCQ toxicity, you will see a particular second line, second grow of this, the trace array will be affected. And that's how you can actually, it's very important in its significances in more of drug toxicity. So, they have a stimulus pattern of usually 61, 103, and 241 hexagons to cover it. Usually around 50 degrees of the visual field is examined. So basically, it's to distinguish retinal disease from optic nerve diseases. It gives a detailed extent of the lesion. It's a sensitive indicator for retinal drug toxicity, and also assess subclinical retinal changes in diabetic retinopathy. So this is the thing I was talking about. So this is a normal multifocal ERG, and this is the plaquenal, that is the HCQ. So what happens, if you can see over here, the peak is okay. You can get a rough idea by looking at the 3D density plot. But if you look at the arrays over here, the second wave, this region is usually classically affected here. So this is very classical of HCQ toxicity. Now VEP, it helps in assessment of the visual pathway. See, basically, the visual cortex is represented, has a major. The macula is mostly. The electrical signal generated in the visual cortex is in response to visual stimulation. So VEP reflects the electrical activity of the subject's central field. So the central retina is projected on the surface of the occipital lobe. So what happens is the foveal projection is magnified at the cortex, which is known as the cortical magnification factor. This is M. So we have the flash VEP, pattern VEP, and sweep VEP. So the flash VEP is basically done in patients with media opacity, very low visual acuity, infants, and uncooperative patients. And the pattern VEP basically for optic nerve atrophy, glaucoma, optic neuritis, and so on. So we have three, so just like the other wave, they have the two negative waves and one positive wave. So this is the N75, this is the P100, and N135. So basically it is the timing. So that is 75 microseconds, 100, and this is at 135. So this is like a picture of an asymmetric optic neuritis. So the right eye, this is the normal VEP. So you can see the N1, P1, and N2 here. If you look at this here, the response is a little delayed, and also the amplitude is affected. So this is how an optic neuritis starts. VEP picture of an optic neuritis look like. And flash VP is done with patients with media opacities and uncooperative patients. Next is EOG. So how do we get an EOG done? So basically what happens is it is done in both dark and light. So with an ordinary light, the patient comes there, you place the electrodes and you start with normal turn of the light and do it for 15 minutes. You take it, do it to the recording for 15 minutes, and then the next 15 minutes you do it in light. So in the dark 15 minutes, so usually what happens is we get an amplitude there, a wave there. So the minimum amplitude distance we usually get around 10 to 12 minutes. So that is the dark trough ratio. And then in the light phase, it's around 6 to 8 minutes you get the peak. So you take the ratio and that's how you get the Ardens ratio. So I'll just take one. So this is a normal EOG. So basically what we do is the light peak to dark trough is multiplied into 100 and we get the Arden ratio. The normal Arden ratio is around 1.8. Somewhere between 1.65 to 1.8 is subnormal, and less than 1.65 is completely abnormal. Thank you.
Thank you, Dr. Rahul, for your exhaustive talk on electro